Today we have the pleasure of hosting Dr. Reshmi, the talk on medical management of obesity. Dr. Srinath is an assistant professor in the Division of Endocrinology, Diabetes, and Bone Diseases at the Icahn School of Medicine in Mount Sinai. She received her undergraduate degree from Yale University and her medical degree from the University of Connecticut School of Medicine. She completed her internal medicine residence and training at Duke University Hospital and completed an endocrinology fellowship at Johns Hopkins. Dr. Srinath currently works in the Mount Sinai Diabetes Center, and her role includes caring for general endocrine outpatients, covering inpatient endocrine and diabetes services, as well as teaching fellows and residents. She is currently building a collaborative weight management center here at Mount Sinai with the aim of working with primary care and bariatric surgery, instructions of care of patients with obesity and associated metabolic complications. Please join me in welcoming Dr. Reshmi.
Thank you. Can everyone hear me okay? Okay, wonderful. So today I'd like to talk about some updates in the medical management of obesity. I should also say medication management of obesity. First off, disclosures, nothing to disclose today. Here are a list of my objectives. So first, briefly, I'd like to hint of the prevalence of obesity as well as the implications here in our society. Then we're going to go to screening, diagnosis as a provider, how we should start this process. And lastly, using recent guidelines and algorithms to guide medical therapy. First, I'm going to start with a case. This is a typical patient who presents to my clinic. This is Mrs. P. She's a 35-year-old Caucasian female who presents for endocrine evaluation. She complains of progressive weight gain, which has started since college. She also notes significant fatigue, heat, cold intolerance, difficulty falling asleep and staying asleep. In the past, she's had issues with hair growth, particularly over her chin, neck. She's tried laser therapy, she plucks, she tweezes, she's done it all. She says her periods are pretty regular, but they tend to be 30 to 45 days in cycle. She recalls that she joined a gym, but really isn't that physically active, mostly due to work and family stressors. And because of her work, she does try to eat healthy, but she tends to eat out mostly during the day at lunchtime. Her motivations are that she's recently engaged and she really wants to lose some weight. Just to sort of briefly run through all of her history. So past medical history, migraine. Social history, she's a lawyer, no real bad habits, no smoking, alcohol. Family history, possible diabetes, and some heart disease, but otherwise everyone else is healthy. Really not using many medications. In the past, she used some migraine medications, which she couldn't really tell me all the names. She says she uses Excedrin as needed, and some propranolol as well, really just to control these and reduce their intensity. Allergies really are none. And jumping to her exam, really the only thing that I found notable is that her BMI, or body mass index, is 29, consistent with being overweight. Her thyroid exam is normal. She does have some mild dorsocervical fullness in the back, and really some pale stria over her belly, but really nothing else pertinent on exam that was striking. So the question I have for you guys is, what other information do you want to know? In no particular order here, I've listed some of the questions I have for her. So obviously, number A, weight trend. Where has she been in the last few years, and particularly in the last 6 to 12 months? Have there been times where she was at a very high weight in the past? And also, where was she at her lowest weight? A food diary. So knowing what she ate in the last 24 hours, really having her recall every meal and every snack is important to see her general habits. Activity level. The level of exercise, if any, and what she does on a regular basis. As I mentioned earlier, prior attempts at weight loss. Has she tried medications, diets, commercial weight loss options? That's all important. Other medication exposure, such as steroids, anticonvulsants, things that can cause weight gain. And then looking at some of the secondary symptoms, so symptoms of hypothyroidism, symptoms of hypercortisolism, and questioning her if she snores, because this would raise the concern for sleep apnea. And lastly, given her plans that she's now engaged, is she interested in fertility, and is that something that's urgent in the near future? Because that is all going to affect how you treat her. Next, in terms of looking at the labs, these are some basic labs that I might pursue. including metabolic panel, liver enzymes, just to look if she has some NASH or non-alcoholic steatohepatitis, screening her for diabetes, hyperlipidemia, and thyroid dysfunction, as well as if she had some complaints, I might pursue a 24-hour urine cortisol to look for evidence of Cushing's. So this is a case that I'm going to come to at the end, and we'll sort of round out and see what we did for her. So going back to our objectives, to talk about the prevalence of obesity and their implications. I think all of us have seen the diagrams of the US, how year by year the prevalence of obesity goes up. This is what struck me. This is released by the WHO just last year, showing the prevalence of obesity worldwide. And as we know, 1 in 3 in the US is obese, but if you look at other countries highlighted in red, these are all countries that have a prevalence over 25%. Again, this does matter how you define obesity, and here obesity is defined as a BMI over 30 kilograms per meter squared. This does play a role when you look at countries like India, China, and some of the Asian countries where the risk of metabolic side effects and comorbidity does increase at a lower BMI. But again, this is just showing you how prevalent obesity is worldwide. When we think about what drives the obesity epidemic, there are a lot of key players. The hypothalamus is what we consider the prime regulator. So there are neuropeptides and hormones being released which stimulate appetite. Those include neuropeptide Y, as well as agouti-related peptide. There are also peptides that suppress appetite. And here I've listed POMC, as well as the CART, or cocaine amphetamine regulated transcript. In addition to the hypothalamus regulating these signals, we also know that the gut and the pancreas play a huge role. And we're now learning more and more about the role of ghrelin and how that can stimulate appetite. We also know that there are hormones coming from the small and large intestines, including GLP-1, serotonin, peptide YY, as well as insulin, all playing a role in suppressing our appetite, increasing satiety, and reducing the risk of weight gain. Fat is now known to be metabolically active with secretion including leptin, as well as inflammatory markers, including IL-6, tumor necrosis factor alpha, and resistance. And these are all playing a role in the drive towards weight gain. The autonomic system, particularly dopamine, serotonin, norepinephrine, play a huge role in driving the reward pathway and our interest in eating. We also know that the environment plays a huge role, which I'm not really going to get into today, but it obviously does affect the risk of obesity. When we think about, from the biologic perspective, what are the genetic and acquired causes, we know that in terms of genetic causes, we know that leptin deficiency as well as POMC deficiency do contribute to general obesity starting at a young age. In terms of syndromes, Prader-Willi, Bardet-Biedl, and Cohen syndrome all are associated with significant obesity starting at a young age. And there are multiple secondary risk factors, including damage to the hypothalamus and pituitary from brain tumors, radiation, as well as hypothalamic radiation. We know that psychologic disorders can contribute to weight gain, including depression, eating disorders such as bulimia and binge eating disorder, as well as endocrinopathy such as thyroid dysfunction, Cushing's, and growth hormone deficiency. Medications such as steroids, glitazones, tricyclics, and multiple antipsychotics all contribute to weight gain and all play a role in the epidemic. The complications of obesity are immense, and we know that there is a direct link between BMI and the risk of type 2 diabetes. We also know that it plays a role in the cardiovascular risk factors, hypertension, hyperlipidemia, as well as heart disease itself. More and more we're learning about these, the risk of PCOS, hypogonadism, as well as sleep apnea. And there's more and more literature about that link and how we can prevent that. From our perspective, we're seeing more and more of this, that people who are obese are considered high risk, particularly when they're pregnant. Obesity can be associated with increased risk of hypertension, preeclampsia, early preterm labor, as well as gestational diabetes and type 2, just chronic diabetes. We also know there's greater risk of macrosomia, or having a baby over 9 pounds, miscarriage, as well as potentially longer hospitalization when they are admitted for labor. From the male perspective, we know that obesity is also associated with lower testosterone levels. This is a study that I did using the ERA cohort, which is a longitudinal study of men and women looking at the incidence and risk factors associated with heart disease. And we found that lower testosterone was associated with a higher body mass index. Given all of this data, all of the implications, there has been a lot of recent focus on how we can consolidate this information and promote the screening and diagnosis. So this first started in 1998, where the National Heart, Lung, and Blood Institute released a clinical guidelines report just briefly detailing how to screen for diabetes and how important it was. This was further elaborated in 2013 when the American Heart Association, coupled with the American College of Cardiology and the Obesity Society, also released their own version of an algorithm and comprehensive guidelines, again, on how to screen and how to use BMI to guide therapy. Further, in 2014, the American Association of Clinical Endocrinology released their own framework. And this framework was sort of a transition. Rather than using BMI, their idea is to focus more on the complications. So this was a big change from prior frameworks. And lastly, we have the Endocrine Society, which released earlier this year, their guidelines in terms of medication management. And this was chaired by Dr. Carolina Povian from Boston University. So what is the rationale for treatment? We know now that obesity is a chronic disease. It is multifactorial in etiology. The associations we know are greater morbidity, mortality, as well as healthcare expenditure and diminished health quality of life. We know now that screening, diagnosis, and treatment is necessary to avoid not only the complications, but to prevent them and prevent progression. So what I'd like next to move towards is, as a provider, how do we screen and how do we diagnose obesity? First, when a patient walks in the door, these are some of the questions that I'd like to ask. First, their weight. I'd like to know their current weight, their maximum or where they were when they were their peak weight, when they were their minimum or their least weight, even if it was back in college, and where they'd like to be, again, establishing a healthy target for their target weight. I'd like to know what they did in the past to attempt at weight loss, as well as their motivation. Is it because they have an event going on? Is it because of complications? Is it because of family pressure? These are all really important in knowing if your patient's truly motivated. Next, as I mentioned earlier, we want to look at their diet. Are they someone who eats out frequently or is doing mostly home-cooked foods? And I want to know detail by detail a 24-hour recall. This is mostly done by asking them, really, what did you eat yesterday? Because that's really going to get them to admit whether they ate that slice of pizza and those wings or if they were eating a salad and soup. Next, obviously, the activity level, how frequently, the intensity, and what they're doing. And looking at social, environmental, and psychological factors, such as who is doing the grocery shopping, who is cooking, who are the ones in the household, and what is kept in the house, and who is eating them. These all play a role in weight gain, as well as I mentioned earlier, the complications and looking for secondary causes such as thyroid dysfunction and hypercortisolism. When we go to our physical exam, in terms of vitals, I'd like to know their body mass index and look at their waist circumference. So this diagram here is just a reminder how we calculate waist circumference. So using a general tape, we can measure at the top of the iliac crest, and you want to measure the maximum diameter around their waist. And this can vary, obviously, depending on the height of their hips. In general, looking at their weight distribution, so are they predominantly, apple-shaped, pear-shaped, or are they having most of their fat in their centrally located? And lastly, looking for secondary signs. Do they have a goiter? Do they have evidence of dorsocervical, supraclavicular fullness, striae? These would all suggest hypercortisolism. Or do they have an enlarged jaw, or things to suggest growth hormone abnormalities? In terms of laboratory assessment, the goal is to really look at complications. These are just some basic labs that I obtain, including screening for diabetes with fasting glucose as well as A1C, thyroid testing, metabolic panel to look at their kidney function, electrolytes, liver function testing, again, to look for fatty liver and complications there, lipids, and again, only if necessary, I would do a 24-hour urine cortisol or DEX suppression to look for hypercortisolism. Using this data, we can then stratify patients, and this is released from 2000 from the NIH, looking at not only BMI, classifying them by BMI as well as their waist circumference. And we know that those who have greater waist circumference, particularly the risk of visceral adiposity, produces a very high cardiometabolic risk. So those who have waist circumference over 40 inches in men or over 35 inches in women, and who also have a BMI greater than 35, are at very, very high cardiometabolic risk. So all of this information needs to be consolidated when we choose and how we guide their treatment. So using this information, we then move towards how we treat these patients. And these are some of the options we have. So diet, lifestyle modification, medications, surgery, and there are now newer alternatives. I'm going to briefly talk about diet and lifestyle. The focus today is going to be on medications, and we'll go over sort of how we proceed in using these. This is the American Heart Association guidelines that were released in 2014. And again, this is just going through what I started. I know it's sort of hard to read, but again, starting with BMI, looking at cardiovascular risk factors, looking at are they ready for weight loss, and then determine their goals, and then looking at their BMI and how they can benefit from lifestyle. So if they do have sufficient weight loss, more than 5%, then they're doing well. However, if that is not met, then we move towards medications or we move towards surgery. So again, this is sort of a general algorithm for how we can assess these patients. And this is the ACE guidelines for their algorithm, how to look at obesity. So these are a little bit different. So rather than being BMI-centric, these are complication-focused. So again, first we start with the BMI. So BMI less than 25, which is considered normal, or BMI 25 or above. And then looking at the physical exam, the labs, and then looking at their complications. So as I mentioned, sleep apnea, arthritis, PCOS, diabetes. And then they distinguish those who have complications versus those who have none. And those who have at least one complication that is severe are considered stage 2, and those who have one or more which are mild or moderate intensity are considered stage 1. And in their algorithm, this is where the distinguishing factor becomes of how these patients are treated, because those who have stage 2 are those who you might consider bariatric surgery or something that's more permanent in treatment. So going back to sort of how we triage and how we stratify and go towards treatment, first I'll talk about diet. So there's a lot of information out there about diet. We know in general that it requires a deficit. This is in caloric intake compared to expenditure. This is about if we aim for gradual steady weight loss, a healthy weight loss is approximately 1 to 2 pounds per week. So this is equivalent to a reduction of 500 to 750 kilocalories per day. We often counsel our patients that the greatest weight loss is in the first few months. Many times they will plateau and possibly regain. This is because as you lose weight, your metabolic rate is declining. You're also releasing hormones from the hypothalamus that are trying to get you back to where you were. So again, that is why weight loss is so hard with diet only. We have multiple diets available. So the very low calorie diet is really less than 800 calories a day. This means eating protein shakes only, really eating minimal food. We also have what's called a protein-sparing modified fast. This is really a fast accompanied by protein in the form of lean meat, protein shakes with no carbohydrates. This is someone who wants rapid weight loss within weeks to months, and this can achieve very significant weight loss very quickly. There are a multitude of low-calorie diets. All are sort of in the range of 1,000 to 1,500 kilocalories per day. We know that the low-fat diet is equivalent to approximately less than 30% fat total per day. We also have variations on a low-carb or high-protein diet. This can be less than 20 grams of carbohydrates, or it could also mean greater than 30 to 40% of protein intake per day. There's a low glycemic index diet, there's a Mediterranean diet, there's also multiple commercial weight loss diets, which all sort of target a target of about 1,000 to 1,500 kilocalories today, which I'm not going to be able to go into as much. Prior to even looking at diets, we know that there are simple benefits from doing very minimal changes, such as cutting out diet soda. This is just a small study that I found recently published in the American Journal of Clinical Nutrition just last month, suggesting that just by cutting out diet soda, we can lose significant weight. So in a study of 89 overweight females, all habitually consuming diet soda with their largest meal, they randomized them to either replacing the diet soda with water or continuing the diet soda. These were incorporated with an integrated weight loss program where they were targeted to limit their diet by 500 to 1,000 kilocalories per day, as well as incorporate regular exercise. And the benefits were significant. At 24 weeks, they found that those who were randomized to replacing diet soda with water had significant weight loss from 88 kilos to 79.9 kilos compared to the diet beverage group. They also had significant improvement in their BMI with a p-value that was reached significance. Improvement in risk of diabetes. So not only their 2-hour postprandial blood sugar, their A1C, their measures of insulin, as well as the HOMA-IR, which is a measure of insulin resistance. This suggests that just a simple change of cutting out diet soda can make a profound impact on weight. Earlier studies looked at a lot of the commercial and the weight loss diets that were out there, and this is a study from 2005 that again compared the Atkins, the Zone, which are pretty much higher protein diets, comparing that to Weight Watchers, which is mostly focused on calories, and the Ornish diet, which is low fat. And I know we've looked at this data in the past suggesting that, and this really meant that maybe the calories were important because Weight Watchers seem to have the most significant weight loss over time. But when they looked at it, they also found that when they looked at dietary adherence, which is here on the x-axis, that those who had the greatest dietary adherence also lost the most weight. So really the idea this suggested was that the diet itself doesn't matter, it's really their motivation and their adherence to the diet that plays the hugest role. This was further studied in another study from 2008, which looked at 3 other diets, the low-fat diet, the Mediterranean diet, and the low-carb diet. And they also showed that very quickly people lost weight, and this seemed to suggest that the low-carb diet created the greatest weight loss. However, if you look at long-term, everyone sort of plateaued, everyone regained, and the weight loss from the matter of kilos was really not that much different between the different diets. So this all seemed to propose that the diet itself doesn't matter, it's the adherence and their motivation to lose weight that really plays a role. More recently, there's been a lot of literature about the idea of fasting. This initially started in the media, celebrities, obviously in times of famine and war. In terms of studying subjects, Ramadan has been a topic where we can look at subjects who are fasting for a long period of time, and a study recently this year suggested that those who are fasting do have greater response in terms of increased insulin sensitivity, glucose homeostasis, as well as improvement in their weight, despite the fact that they're not eating all day and then having a very large meal. We know that fasting can contribute to significant weight loss. However, the studies suggest that this is both a loss of lean body mass as well as fat. Now more and more there are researchers just recently presenting data at the Obesity Society last month suggesting that if you manipulate the fasting, if you use high fat versus low fat meals, high carb versus low carb meals with the fast, that you can create greater weight loss. And that data really hasn't been released yet, but is something to look forward to because we really don't know the long-term benefits of fasting and how safe it really is long-term. Obviously, as I mentioned, the limitations in diet, so one is difficulty in caloric restriction. Obviously, the idea that it's hard to sustain. Many of these diets are hard to continue for more than a few weeks of time. And also the concept that a lot of it promotes weight regain. So within a few weeks or 2 months, weight is regained and patients plateau. And that makes us consider that it's important to combine the diet with exercise. And by incorporating exercise, we can promote loss of fat mass rather than lean body mass, as well as improve insulin sensitivity and their metabolic rate. The current guidelines suggest at least 150 minutes a week or 30 minutes 5 days a week, continuous or intermittent, and resistance training is recommended and beneficial. Earlier studies have suggested that exercise is a predictor of long-term weight success. So this was a study released over 10 years ago in a population of sedentary obese females, where they showed that women who were randomized to a weight loss program, in addition to exercise, either less than 150 minutes, greater than 150, or greater than 200, and they found that those who had the greatest component of exercise actually lost the most significant weight. So again, promoting the idea of exercise as an important component of weight loss. We also know that large-term studies have promoted the idea of exercise and the idea of combining lifestyle benefits. So the Diabetes Prevention Program is one of the largest randomized prospective studies looking at those who are at risk for diabetes, and those randomized to intensive lifestyle changes had a risk reduction of 58% in terms of their risk of diabetes compared to those who were on placebo or lifestyle. And here, this is sort of graphed here, where those who were randomized to intensive lifestyle had the least incidence of diabetes risk. We also know recent data from the Look Ahead trial where we were looking at the role of intensive lifestyle in obese type 2 diabetics, and this suggested that just at 1 year, there can be an average around 8 to 9% weight loss compared to placebo using just intensive lifestyle. So again, promoting the benefits of combining diet and exercise. However, when diet and exercise are inadequate, we then need to consider weight loss medicine, and really to see if these are even necessary. So the important is that this should be used in conjunction with diet, exercise, as well as behavioral counseling. It's targeted for those who are considered obese or overweight, who have comorbidities or have failed in the past. Many of these weight loss medications are contraindicated in pregnancy, and I'm going to go through those in more detail. Prior to even starting a weight loss medicine, we first need to look at their use of medications and what might be contributing to weight gain. So we know in diabetes, we want to use medications that are weight neutral or that might produce weight loss rather than just using insulin, which can contribute to weight gain. In the setting of hypertension, we know that using medications rather than beta blockers might contribute to greater weight loss and not promote weight gain. In the setting of depression, psychiatric disorders, again, considering weight neutral medications. In autoimmune conditions, trying to focus on using the least dose of steroid possible. And in HIV, monitoring the side effects of antiretrovirals, as well as the body composition changes that occur with HIV itself. So as a diabetes specialist, we always want to know what is the best for our patient to promote greatest glycemic control. So the issue is that we need to balance this with the risk of weight gain. So we know that insulin is our most potent drug, but it does promote up to 3 to 4 kilos of weight gain per year. We also know that sulfonylureas, even though they may promote a reduction in A1C by 1 to 2%, they also contribute to significant weight gain. Other medications such as Prandin, Starlix, as well as TZDs all promote weight gain. And so the idea is that to balance this with the idea of losing weight or creating a weight neutral medication. And so ideally, we'd like to replace or add a medicine that might contribute to weight loss. So these options might include alpha-glucosidase inhibitors, which can contribute to up to 1 kilo of weight loss per year. Or obviously Metformin, which is our gold standard, and can contribute to weight loss up to 3 kilos per year. More and more, we're seeing recent data about the GLP-1 agonists, which include daily injections as well as extended release weekly injections, and those can lead up to a couple kilos just in a pattern of 26 weeks. As well as the DPP-4 inhibitors, which may not contribute to weight loss, but they're actually weight neutral. So the idea is that if someone is on multiple injections of insulin, making sure that they're on metformin or adding a GLP-1 or a DPP-4 inhibitor can reduce their insulin needs and promote weight loss. After optimizing all their medications, if weight loss medications are necessary, the next step really is to have a discussion with their patient. So we'd like to know the general patient preferences as well as their concerns about drug side effects. They need to know that if they start on a weight loss medicine, they will need frequent monitoring of their blood pressure, pulse, weight, electrolytes, as well as noting side effects. In general, our target weight loss is 5% at 3 months with all of these drugs. And if this is not achieved, we then move towards more permanent options or alternatives. This is a list of the current single agents for weight loss. So our older agents include orlistat, which is a pancreatic lipase inhibitor, as well as phentermine, which is an amphetamine derivative. Newer agents include lorcaserin, also marketed as Belviq, and liraglutide, an extended formulation which is also called Saxenda. These are all doses that are titrated, and as you can see, have some side effects that have to be monitored. And these I'm going to go through in detail. What I didn't list in that medication is metformin. Metformin is not FDA approved as a weight loss drug, but it is something we know has significant benefits. We know this is because of its unique mechanism, not only reducing glucose production, but improving the sensitivity to insulin and improving satiety. We know that in trials such as the DPP, there was significant weight loss seen, and this was sustained over up to 10 years. Studies have shown this benefit in prediabetes, diabetes, as well as in PCOS. So no FDA indication yet, but it's something to use in diabetics or those certain populations which you think are at risk. Jumping to orlistat, this is one of our older drugs. So this was one of the largest studies, over 3,000 patients, published in 2004. These were patients who were at risk for diabetes, and they found that those who were randomized to orlistat and lifestyle had significant change in body weight, up to a loss of 9 kilos, compared to those who were using placebo and lifestyle. So this seemed to suggest the benefit of orlistat. Obviously, the side effects include significant gas, flatulence, diarrhea, which all have to play a role. Orlistat is now marketed as a weight loss drug, but there's also an over-the-counter formulation called Ally, which is a lower dose, about half the dose that is normally given prescription. So patients can try the over-the-counter, or they can try the prescription, whichever they prefer if they're interested, obviously taking into account the side effects. Next, going to phentermine. So phentermine is probably, again, another older drug, initially approved in 1959. It is now the #1 prescribed obesity medication, despite the known side effects. And how does it contribute to weight loss? Is through suppressing the appetite and really as an amphetamine derivative. Doses usually start at 15 milligrams a day. This is actually being worked on right now. There's a new formulation that's going to be soon released at 8 milligrams. And again, the concern is about these adverse side effects. So this can include elevated heart rate, blood pressure, insomnia, dry mouth, as well as signs of anxiety, agitation. The issue with phentermine is we don't have a lot of recent data. All the studies were done in the 1960s to 1970s. They all had a very, very high dropout rate, and none of them were more than 36 weeks in length. So we really, when we prescribe phentermine, we only give it for a short period of time. We say, use it for 3 months. It's not recommended more than that. And if it's not creating a beneficial effect in terms of weight loss, we move to something else. So again, using recent guidelines, it's not recommended as chronic therapy here. A newer agent is Belviq, FDA approved in 2012. So this is selective for the serotonin 2C receptor. This is compared to prior drugs such as fen-phen, which had increased risk of valvulopathy. Efficacy trials have been performed. These include Blossom and Bloom. These were at 1 and 2 years duration, which showed significant weight loss, about 3 to 4% of their total body weight, as well as improvement in cardiovascular parameters. Significant effects include fatigue, constipation, dry mouth, and headache. Again, these are tending to be less severe and sort of transient in nature. Patients who are on other serotonin agents should not be allowed to take this drug because of the risk of serotonin syndrome. We know also in these trials they did look at the risk of valvulopathy, and they looked by echocardiogram and found no significant increase in valvular disease. So that is reassuring given we know the risks that were seen with prior uses of other serotonin agents. So this is the Bloom study. This looked at over 52 weeks weight loss associated with Belviq. And these were patients who were overweight or obese, over 1,000 randomized to treatment or placebo. And they found that over 45% lost more than 5% of their weight loss, which was significant compared to placebo. They also found that about 10 to 15% lost more than 10%. Over a period of time, again, this weight loss was on the range of 5 to 6 kilos. And this was felt to be significant compared to placebo. One of the critiques of this study was that, again, there was a high dropout rate, and the weight loss, if you think about it, maybe 45% lost more than 5%, but that means 55% did not lose more than 5%. So this is, again, a criticism of Belviq and a question about its efficacy compared to other weight loss agents. The benefits are that the side effect profile is quite minimal compared to some of the agents I'm going to discuss in the future. Next, we have Liraglutide, which is probably our newest agent. This is Saxenda. It is an extended release formulation. Already we know that it's approved in type 2 diabetes, and this is in the form of Victoza, Trulicity, and other forms of GLP-1 agonists. Long-term studies have suggested the weight loss can be at least 5% at 56 weeks. Unfortunately, again, the limitation here has been a bit of side effects. So most commonly, we are seeing nausea, vomiting, gallbladder disease, and in the study that was published in the New England Journal earlier this year, they found that 65% of the treatment group occurred these side effects compared to 39% of the placebo. And this was the largest phase 3 study that we have. Again, this study seemed to suggest that the side effects were transient. They were tending to be mild or moderate in nature, and they did resolve with time. But I think the benefit of this agent is that in diabetics, it is an optimal agent because it can contribute to weight loss. It is going to help with insulin sensitivity. What we don't know is the risk of hypoglycemia. So if a patient's already on insulin, if they're already on a sulfonylurea, can that create increased risk of low blood sugar? The other issue with this medicine is obviously cost. It can cost up to $1,000 a month. Insurance is not going to cover it, but there can be coupons, and some insurance companies can assist with that cost. This is a study from the New England Journal that was published earlier this year by Qsymia et al. So this showed in those who were randomized to liraglutide versus placebo, here in the blue, that there was significant weight loss, up to 10% at 52 weeks. And this is using the intention to treat population. Here we have, in terms of weight loss, over 63% of those who used liraglutide had greater than 5% weight loss, and 33% had greater than 10%, with almost 15% having greater than 15%. So this would seem to suggest that this is one of our most potent agents to date that has come out, which would be helpful with weight loss. The study also looked at patients who had risk of diabetes and found that there was reduced risk of diabetes conversion. So in the blue, we have here liraglutide and patients who are receiving a diagnosis of diabetes on the y-axis. And as you can see, compared to placebo, there was a significant reduction in this conversion. So again, suggesting that this agent can be used not only in diabetics, but also non-diabetics and those who are at risk for diabetes. Next, I'd like to go to combination drugs. So these are our two newer agents. We have a combination of phentermine and topiramate, which is also known as Qsymia. And we have Contraries, which is bupropion and naltrexone. Phentermine and topiramate are felt to be acting at the hypothalamus via catecholamine modulation. The doses are titrated. Similarly, bupropion and naltrexone are a combination that are felt to be acting on dopamine, norepinephrine, as well as the opioid receptors. And so we'll talk about what that means in terms of side effects. So first, starting with Qsymia. This was approved in 2012 by the FDA. There are at least 3 to 4 dose formulations. So we usually recommend starting at the lowest dose, which is 3.75 of phentermine and 23 of topiramate. This is usually for about 1 to 2 weeks. Once that's tolerated, we then titrate up. And so we then go to a double dose. And if necessary, at 12 weeks, if a patient's not experiencing significant weight loss, we then can go up to a 15 milligram and 92 milligram combination dose. This has been demonstrated to be very highly efficacious, so we have multiple studies that were phase 3 with over 1,000 patients suggesting that this is contributing to significant weight loss. Adverse effects noted in all of these studies included the risk of dizziness, dysgeusia, which is a loss of taste, paresthesias, as well as insomnia. Most of these were felt to be secondary to the topiramate, but the idea is that by using an extended formulation, the side effect profile might be less. These were again noted to be greater than 1.5 times the risk in placebo-treated patients, and it was also felt to be dose-related, so that's something to keep in mind. In patients who have heart disease, hypertension, which is uncontrolled, this medicine is contraindicated given these known side effects. So again, these are useful in healthier patients who have obesity without the other complications. This is the sequel study. This was over 108 weeks in patients randomized to Qsymia at varying doses. So we have here in the diamond-shaped placebo, we have here in the square the phentermine, which is at the moderate dose, and phentermine and topiramate at the highest doses in the triangle. So as you can see, this is the least mean squares weight loss in percentage, and those who were randomized to the highest dose had the greatest significant weight loss over a period of 108 weeks, which reached significance. Again, suggesting that when a patient uses this medicine, they need to be titrated up to the maximum dose, at the same time monitoring for side effects. Next, jumping to Contraries. This was approved just last year in 2014. And this is felt, I know a lot of people have concerns about the naltrexone component, but it's felt to act synergistically with bupropion in terms of modulating hypothalamic output, affecting reward pathways, and reducing craving and intake. Multiple phase 3 studies have suggested this is both efficacious and beneficial, and I've listed some of those here. Core 1, Core 2, as well as multiple other ones. Again, side effect profile plays a role here. So the most common side effects noted were nausea in about 29 to 34% of the treatment group. We also know that dry mouth and constipation were also noted. So this is something to keep in mind. This medicine is started at 1 tablet a day. After a week, we then titrate to 1 tablet in the morning, 1 tablet in the evening. And every week, consequently, it's titrated upward. So at 4 weeks, they are taking 2 tablets in the morning of the 8/90 milligram formulation and 2 tablets in the evening. The idea for this titration scheme is to minimize side effects and to ensure greatest efficacy. Again, this medicine, given the side effect profile, is contraindicated in uncontrolled hypertension, people who have severe opioid use or abuse, people who have recent use of MAOI inhibitors, as well as those with seizure disorder. It might be beneficial in someone who's obese, who has history of depression or history of smoking, because it can affect the addiction pathways and the reward pathways and really assist with significant weight loss. So again, this medicine is probably appropriate for a healthier patient without the comorbidities that we typically see with obesity. So in general, looking at that summary, we know that many of these agents are proposed to help with weight loss short term. Again, the titration scheme is targeted at about 12 weeks. Weight loss is usually seen within those 12 weeks, and once the medicine is stopped, we tend to see weight regain. Within those 12 weeks, if weight loss is not seen, we tend to recommend switching to an alternative medicine in a different class or considering a more permanent option. Here I've got a table of the medications, and this was from the recent guidelines chaired by Dr. Apovian, and again suggesting the advantages and disadvantages of all these agents. So as we mentioned, phentermine, the advantage is it's probably one of the cheapest medicines out there. The disadvantages are the side effects, and that we have no long-term data. So really, after 3 months of treatment, there's no data on how to guide therapy. Using Qsymia, we know that there's significant weight loss, but again, the issue are, again, side effects, expense. Belviq, again, expense. Benefits are that this probably has the least side effect profile of all the agents we have, but the data for Belviq is probably not as good compared to the other agents. Orlistat, both prescription and over-the-counter, is inexpensive. There's a lot of data, but we know that the weight loss is probably not as much compared to newer agents. And lastly, naltrexone and bupropion. That combination is beneficial in a certain population of patients, but there are significant side effects, and that the price range is sort of moderate. And Saxenda probably is our most potent agent, but it is probably the most expensive. So again, that has to be weighed into all of this. Obviously, if medications don't work, the next step is bariatric options. So we now have multiple bariatric options, which I'm not going to go into in detail, but obviously we have gastric banding, we have gastric sleeve gastrectomies, and we have the Roux-en-Y. So if a patient were to fail medical therapy, or if they were to come in and not want medical therapy, the option always is to move towards bariatric surgery. And this is something you can keep in mind as well if they are very severely obese. So if their BMI is over 40 or over 45, then they should be pushed more towards bariatric surgery rather than using medications from the start. Current indications for bariatric surgery include, as I mentioned, BMI over 40, or a BMI over 35 with a complication of obesity. We also know that there are now more and more studies being performed with those who have a BMI between 30 and 35, who have uncontrolled diabetes as well as severe complications from the obesity, and those have shown beneficial outcomes. Contraindications include active substance abuse, untreated binge eating, depression, as well as psychiatric disorders, coagulopathy or severe heart disease, as well as inability to comply with the stringent dietary program that's necessary post-surgery. So these are all things to keep in mind when you have a patient and you're trying to guide their therapy. One of the newest things that's come out is the Maestro. This is a really implanted neuroregulatory device that affects vagal output and can contribute to reduced satiety as well as reduced intake. This is something that we've not had great experience with, but it is FDA approved. And then in July, we also have even a newer device, which is the dual balloon. This was FDA approved in July of this year. This is a dual balloon that is endoscopically inserted, and it is placed within the stomach, inserted with saline, and that saline pretty much reduces satiety and helps reduce intake. We may not be doing this significantly here, but we do know that studies in Europe have shown significant benefits. And they are doing this very commonly with good outcomes and less side effects. So these are all things that might be coming down the loop. So just to summarize here, I've gone through a lot of information, but the first thing as a provider, we start with screening. We then obviously want to start with lifestyle changes. That includes diet, exercise, and combining those in the most optimal way. If diet and exercise are insufficient, we then move towards medical therapy, and I've gone through numerous of the medical options, both prescription, non-prescription, and how to use those. And lastly, if medical therapy fails, or if the patient is not interested or has severe obesity with complications, we then move towards using bariatric surgery and potentially considering some of these medical devices. So this is sort of a triage scheme that one can use when seeing patients here in our clinic. So I'm going to get back to our patient. This is Mrs. P. So these are her lab values, just to summarize. So again, normal electrolytes, renal function. Her liver enzymes were actually normal range. She did have an elevated A1C of 5.9%, which is suggestive of prediabetes and risk of diabetes. Her lipid panel showed elevated triglycerides with an LDL that was okay, HDL that was also okay, thyroid function was normal, and we did have a nutrition evaluation and a sleep study pending. So given all this information, she obviously was very highly motivated for weight loss, and the question is what real options should we use? So these are some of the things I threw out to her. She clearly wasn't interested in side effects and said the combination agents were not for her. So personally, any of these would be a good option. My number one, I told her, would probably be metformin, given she's pre-diabetic and she's interested in weight loss. Another good option might be using Saxenda, if we can get approval and she's willing to pay. If she's interested in reducing side effects, lorcaserin or Belviq would be a good option just because of the lower side effect profile compared to the other agents. And if she's willing to do something over the counter, obviously orlistat. Given some of her issues with migraines and other complications, I didn't really think phentermine was a good option, just because also she's young and I didn't want to get her addicted to a medicine that we would not be able to stop long term. So with that, I'd like to summarize. So again, what I've talked about today is that obesity is a chronic disease, requires assessment really at every visit and close monitoring. As a provider in the primary care clinics, we should be really in tune to early screening, as well as looking at those who have highest risk of cardiometabolic complications. There should be a stepwise approach to treatment, starting with lifestyle. We know now that medical devices, as I've shown here, are growing, and the idea that they may be coming soon here. We need obviously more research, so that is really crucial, looking at the benefits of these medicines, long-term consequences. Many of the studies are usually 1 to 2 years in duration, so we really don't have the 5-year or the 10-year outlook. And so that's sort of the next step. And so with that, I'd like to thank everyone. I'd like to acknowledge Dr. Tomer, who recruited me here and who has been very supportive. I'd also like to acknowledge Dr. Apovian, who works at Boston University, who I had the opportunity to work with earlier this fall and shadow her in her clinics. And then my mentor from fellowship, Dr. Adrian Dobbs from Johns Hopkins. And obviously, the Mount Sinai Diabetes Center has been wonderful and very supportive. Thank you, guys. So, any questions? Yeah.
The data you showed for weight loss in people who stopped drinking diet sodas.
Sure.
I'm wondering just about the proposed mechanism you thought for weight loss.
Yeah, it's hard to say. I think we now more and more are getting more information that use of diet, these sugar alternatives, alternative sweeteners can also create insulin resistance. They do go towards pathways that can promote weight gain. So it's a hard thing to talk to patients, especially diabetic patients, because they always have been told, avoid the sugar, avoid the soda, use diet soda. But if it's possible, the idea is that you should be cutting out the soda completely and trying to use water, whether it's sparkling water, regular water, trying to replace that. I don't think we know yet the true mechanism. But this was a short study, and we definitely need more longer-term studies looking at the benefits of cutting out soda completely.
Yeah, at the end of your talk, you mentioned a nutrition evaluation.
Yes.
I assume, I'm leaping to think that was by a nutritionist.
Yes.
Is there any data to show that in the 15-minute PCP office visit we have, that we don't deal as well with this chronic disease as nutritionists do?
Yeah, that's I don't know of any studies looking at that. It's definitely hard within a short period of time to really get that 24-hour diary. And so what I tend to do is I tend to try to do a 24-hour food diary with them, go over it, and then obviously all the patients sort of want a diet. They want a prescribed diet. They want to have a diet plan. And so I sort of start them giving them recommendations on what foods they should eat. But eventually, I think working with a nutritionist is something that can be happening more often, and they can have more one-on-one time. So I think it's definitely beneficial to have a nutritionist work in conjunction with you. But I just don't think as a provider we can't do it all ourselves. It's just not possible in the time limits we have. Dr. Tomer?
Yeah, I have a comment and a question.
Sure.
So regarding the diet sodas,
Yeah.
there is no one study that has ever shown that diet sodas versus regular sugar sodas actually causes you to lose weight, even though that's how it's advertised. There's small anecdotal studies here and there, but nothing conclusive. On the other hand, there are studies about the diet sodas that are also predisposing to diabetes. There was a recent study published in Nature out of the Weizmann in Israel that showed that the artificial sweetener, all of them change the microbiome, and that was inducing in mice and in humans propensity for insulin resistance and diabetes. So this is a very hot topic now.
Yeah.
And the question for you is, would you want to comment on the new recommendations by Endocrine Society that are calling for obesity first before you treat the diabetes, try to treat the obesity, which is a total paradigm shift for us?
Yeah, I think the idea is that, and all of these algorithms are looking at it differently, but I think they are definitely proposing that when a patient walks in the door, looking at their BMI, looking at their risk of complications first, and treating that. And I personally think that's key. I think if someone comes to me with obesity, I think the idea is if we can treat this first, we can prevent later down the road the risk of diabetes, heart disease, and I think it's getting more and more important to catch it early and catch it when they're younger and to prevent later on. Because once they're on insulin, it's just that much harder to promote weight gain, and we know also that the brain is sort of working against you. As you gain more and more weight, you create a set point, and it gets that much harder to lose weight. So this is why it's important to catch it early and start. So I agree with that sort of framework.
It's a very nice talk. As a cardiologist, I just worry about the look-ahead data. Everybody quotes the 8% 1 year and then an absolute 3% even down to 8 years. But somehow the part where it was stopped for futility with no difference from cardiovascular events never makes it into any slide.
Yeah, they didn't see them.
It seems like the diabetes, obesity nut is a difficult one to crack from the cardiovascular perspective. We seem to have done all the right things which we should do epidemiologically. It doesn't translate into actual cardiovascular events.
Yeah, I think it's a question of what outcome we're looking for. I think, whether they had enough patients, whether there's, the significance. I think definitely the benefit of lifestyle, the benefit of the weight loss, but you're right. None of the studies long-term for any of these medications have looked at cardiovascular, like true cardiovascular events. They've looked at cardiovascular parameters, but you're right, we don't have that data yet. That's something that needs to come.
Two last questions.
Yeah, considering the statistics of how much obesity is prevalent in this country, I think we can say that we have a long way to go in controlling the problem. And I think one thing that really should be emphasized and looked into is pre-K education of children as a preventative method. I know it works a lot in cardiology and other fields, and I think this is something that can really work in pre-population.
That's a great idea.
So it's really interesting that naltrexone looks to be effective, and I was just wondering if you could comment on what's going on in terms of evaluation of obesity as an addiction and the kinds of addiction medications that are being tested and what that might mean in terms of stepped approaches.
I think we definitely know that certain patients have certain cravings and they want certain foods, so I definitely think it can be addictive to want to binge on carb-containing foods. We know that the satiety, the reward pathways all indicate that the higher fat foods are more satiating, more, we crave them more and the rewards are greater. So I agree that using a medication, naltrexone, using these modulation of the hypothalamus, this is the route that we're going. And if we can target the hypothalamus, which really is our key regulatory, in our body, that is what we need to do. And it's very hard. So all of these are starts, and naltrexone is one agent. Obviously, it's going to work synergistically with bupropion, but that modulation is really key here. I agree. So,
Thank you very much.
Thank you guys. Thank you very much.